well, it's gonna show up on this screen, so I might move if that works. Is that okay? So welcome to the Notifiable Conditions series. My name is Kristen Hosey. I'm the interim health administrator here in Chelan-Douglas at the Chelan-Douglas Health District, and we are in Wenatchee at Wenatchee Valley College right now. We've got a few people in the room eating snacks, but I'm happy to have folks on Zoom too that are able to jump in. I know that your lunch breaks, and a commute can kind of add to, especially if you're in Okanagan, not being able to make it. And I have with me our health officer for Chelan-Douglas and Okanagan counties, Dr. Wallace. And so we'll kick off the beginning, and we have special guests here that will talk about measles. So again, if you are on Zoom, please mute your mics. I just wanted to say a special thank you to the Central Washington Area Health Education Center, which is based out of Wenatchee Valley College. I have in the room here Nancy Spurgeon, who's are you still interim, or do you consider yourself? I'm going to call her the full director for Central Washington AHEC, and they are our gracious host each quarter for these events. So as mentioned, the presentation is being recorded, so please sign in. We'd like to know how many people are here so that we can have a head count and also send a survey after. If you're here in person, the bathrooms are just around the corner right here for housekeeping. Parking passes are here. If you haven't gotten one, they're right at the front. And we have a physical sign-in sheet. And we also have some handouts for notifiable conditions. So we have these laminated, and if you're around and you ever want us to give you ours, this is for Chelan-Douglas Health District. It has our contact information on it, but generally each of the health districts or departments have their own modified version. But you can have it posted up in your clinics, in your schools, with your nurses, etc. If you're on Zoom, please write your name in the chat and the title of your organization, your title and your organization in the chat. If you're not part of our series, it would also be great to have your email so that we can shoot you an email, keep you connected with our upcoming notifiable conditions events. And please stay muted. We can put your questions in the chat and we'll take them at the end because we have a pretty quick, we've got a lot to cover today. All right, so if you have to leave early, we're going to just run through for this hour our presentations, but then if you need to leave and we're still asking, people are still on for questions, make sure you stay connected with us. You can register for a series by shooting us an email or dropping your email in the chat. You can, we'll have a survey to send out, and our next event is going to be on August 1st. So in the survey, we ask you, like, what would you like as a topic? And so we'll keep that into consideration for the next event. And so today we're going to just review, I'm going to do a quick review of what notifiable conditions are, since that's the title of our series. And then I'll turn it over to Dr. Wallace, who's going to give an update on pertussis activity in our area, because if you didn't know, we have had a lot of cases. And then he'll review some measles information, treatment and control measures. And then we're going to turn it over to our esteemed colleagues at Clark County Public Health, who will be able to give the real life local health experience in addressing measles. And then we'll have our questions at the end. So zipping through this, notifiable conditions in Washington, there's groups of that need to notify the local health department, and in Wenatchee, that's the Chelan-Douglas Health District. If you're up in OMAC, that would be the Okanagan. And so you're legally required, these groups are legally required to notify us of suspected or confirmed cases of select diseases or conditions. This is all found in WAC 246101, and I even have here just a screen grab of, there's an entire table that kind of goes through each of the notifiable conditions. So this would be healthcare providers that should be reporting any suspected or confirmed cases that are on this table. Healthcare facilities also, laboratories, food service establishments, if there are outbreaks and other things that come out from this list, childcare facilities, schools, and actually, we're not going to talk about it today, but also veterinarians and other groups have some reporting requirements as well. So it's really important that we are notified of these conditions because of surveillance. And so surveillance and reporting help prevent the control and spread of disease. So this includes what we're going to talk about today, which is looking at disease trends, as well as it helps identify and control the sources of infection. So we're like, where is this coming from? If it's environmental, etc. Can also help prevent disease in other individuals or groups. But also surveillance helps us be able to inform the public and say, this is an issue. Look at what's, this is the data we have. And that's the public. We can also inform policy decisions as well as healthcare facilities to make good decisions. In this circle, I always like to include the CDC's 10 essential public health services, just as a reminder of what public health does. You can see on the outside, it has of the circle, there's assessment, policy development, and assurance, like thinking like quality assurance. Today, we're mostly going to be talking about that assessment piece. So the red categories that talk about assess, monitor, and monitor population health, as well as investigate, diagnose, and address health hazards and root causes. But the other ones are also essential in the work that we do at public health. So notifiable conditions have 4 levels. So this is any case that comes in that's on the list that's suspected or confirmed. There's some that need to be notified immediately. And for notification, we ask that you call the health jurisdiction, which is us, and speak with a live person. We have a 24-hour phone. So we're all on call various days. And so please chat with a person about that case if it is in the immediate category. They must be treated as soon as clinically suspected. But then there's some that are within 24 hours. If it's during business hours, we're there. We can see a fax. You can call as well after hours. And then there's some that are 3 days and some that are within 30 days. Today, we're going to talk about measles and pertussis. So kind of wanted to ask like what you guys thought would be for pertussis and what would be for measles. So think in your head, do you think it's immediate, 4, 3 days, or we don't need to know for 30 days? Oh, somebody's smiling in the room. I think they know. So pertussis is within 24 hours. So that's if you suspect it even, right? So a person comes in and they have those clinical symptoms that really you're thinking, oh, I think this might be a pertussis case. Please let us know. Okay, so that's healthcare providers in the facility should be reaching out to us. And again, during business hours, you can send a fax. Or after hours, just give us a call. And measles. Measles is immediately, we want to know right away. Okay, so not only do we expect to hear from healthcare providers in the facilities and anyone that was on that list, the lab also has an ask to also send those results to the public health lab within 2 business days. So immediately for notification, but also just an extra note for our lab staff. So you can send us a fax or a case report, or you can call us, but we want to know ASAP so we can get a handle on it. Okay, that's it for me. I'm going to turn over to Dr. Wallace for the remainder for his section. Thank you.
Thank you, Kristen. Good afternoon, everyone. I'm Jimmy Wallace. I'm the health from Chelan-Douglas and Okanagan County as well. Have been talking a lot about pertussis, so wanted to update everyone on the call. I think many people are maybe familiar, hopefully not tired of this slide that I've shown in so many presentations. I won't go into the detail on clinical presentation, but just wanted to make a few comments as we continue to see pertussis. Many clinicians are familiar with the classic progression of the catarrhal paroxysmal convalescent progression through phases. Very often, patients are presenting early with mild URI symptoms. And so we're continue to encourage healthcare providers to take a really good history, recognize those patients who have been exposed and are experiencing very early symptoms. Go ahead and consider those suspected cases, report the case, go ahead and start treatment and a prophylaxis as appropriate for their contacts. Fortunately, in the cases that we're seeing, we're not seeing the degree of complications that we were worried that we would. Have not had hospitalizations. We've only had 2 infants exposed to or have contracted pertussis. And we think that's in large part due to the great work that many people throughout the district are doing to identify pertussis early, provide appropriate treatment, recommend isolation, prophylax individuals that are at high risk. But I think the vaccine is also working. The pattern of illness that we're seeing suggests that those youngest patients throughout the population, youngest individuals throughout the population have been protected, and everyone has been protected from more severe illness, and transmission has been reduced. I hope that our folks on the front lines and members of organizations with healthcare providers on front lines will continue to really promote the message to communicate clearly the importance of 5 days of isolation for cases, be it suspected or confirmed cases. Antibiotic treatment, post-exposure prophylaxis with a preference and priority for infants, people who are pregnant, or people who are they themselves in contact with those high-risk individuals. And then continue to promote the vaccine, not just the childhood series, but boosters for adults and for each pregnancy for people who are pregnant. And then, as with all respiratory illnesses, continue droplet precautions, masking when people present with respiratory illnesses, as well as good respiratory hygiene. Our jurisdiction is now leading the cases in Washington that we've seen in the past 4 months. Pertussis was rising in late 2023 in Washington state, but we had not yet had cases with us. Now into 2024, our incidence and rate of new infections is much higher than anywhere else in the state. So we're watching it closely and continue to put a lot of effort into it. This is our local epi curve. You'll recall that we had our first case that we were notified of, diagnosed on February 2nd, but that individual had likely been contagious and at school since the 2nd of January. So we knew that we were dealing with a potential long duration of contagiousness. And soon, a week later, had our first lab confirmed case. A couple weeks later, had a second school that was involved that was not linked in any way that we could discern to the first case in the first school, or any of the cases in the first school. In March, we had 2 cases that were in the community and not linked to any other known cases or schools. March 12th, we had a 4th school that was involved again with no epi links to any of the other schools. At that point in time, our health jurisdiction stood up an incident management team, brought in a lot more resources, and have been working hard ever since then. 8 schools involved now, and we currently have 76 cases that are either confirmed or probable. You can see the distribution here among schools and within the community. The age distribution, again, fewer infants and young kids have been affected than middle school and high school age kids. We have seen the majority of our cases having full vaccination coverage, but that's not a surprise to us with what we know about the vaccine. It will not prevent all cases, but is doing a good job of preventing severity and preventing the strength of the virus to infect other people. If you look at epi curves broken down by school, the names of the schools aren't listed here, but I can tell you that we've seen more cases in high school and middle school than we have in elementary schools. We're fortunate to see that in those schools that have had a couple of cases over time, they've not blossomed into more cases. A couple take-home points there. I'm pretty confident in my ability to say now that we are having pertussis cases identified by schools, reported oftentimes by schools, and we've grouped them by schools to help us in our contact tracing. But in the deep case investigation that we've done, that school nurses have helped us with, we've been able to identify that there's more transmission going on throughout the community than there is actually in the school setting. Many of the cases that do have epi links have been within families, household contacts, and then at homes of people who have had sleepovers and close contact for longer periods of time. We continue to coordinate with healthcare, coordinate services, and communicate with schools. Really appreciate all that communication within organizations that we're working with, and we're happy to continue facilitating communication between organizations. We're certainly working hard, as I said, with our incident command structure, have brought in more resources internally, and really appreciate the work and help that DOH has provided. We've learned a lot in this process, and I'm glad we're learning through pertussis because it gives us the opportunity to use these lessons to apply if and when we see a measles outbreak. So I want to talk briefly about measles and then pass on to our guest presenters. Measles was eradicated from the United States in the year 2000. So that declaration was made when the U.S. went from seeing over 500,000 cases before the wholesale or the MMR vaccine in the 1960s, where there were 450 deaths per year, tens of thousands of annual hospitalizations, thousands of cases of encephalitis, down to that declaration of eradication in 2000, incidents less than 1 per 100 million residents in the US in 1997. We haven't had a case of measles in Chelan-Douglas since before 1997. And our cases in the US reached a low in 2004. But since then, with countries in which measles remains endemic, with economic, political instability, and the rise of global travel, as well as a decrease in vaccination rates, we're seeing a return. And so 2019, the US saw over 12,000 cases of measles. You can see in the charts that I've provided there, there's been a slow rise. And as people probably know, 2024 has been a year where we've seen 128 cases. Philadelphia and Chicago have been heavily publicized, but we have had cases in Washington, so Spokane and then Clark counties have had measles cases reported this year. But I think the health jurisdictions there have done a really good job, and I think we've got some things to learn. And so I'm excited to have Dr. Melnick and Clark County with us today. I hope that our response on the front lines and within our health jurisdictions can be as strong as those other counties that have done a good job in controlling measles outbreaks. Healthcare providers need to be aware of the clinical features. They're pretty distinct. So that prodrome that we learn about in school, but rarely ever see, of cough, coryza, conjunctivitis, progressing into fever, and then resolving shortly after a rash comes on is pretty specific for an illness. Healthcare providers should take a history of vaccination status as well as travel history, because again, oftentimes we see this either in folks that have recently traveled or who are in close contact to individuals who have recently traveled. It's important to understand what labs to collect immediately. So a nasopharyngeal swab and urine to be sent to our public health lab. That immediate notification that Kristen mentioned, it gets you access and rapid transport to our public health lab. And we certainly want to avoid complications, especially for at-risk populations, and continue to communicate the importance of vaccination. The MMR vaccine, when offered in the current series, is 97% effective. It's one of the most effective vaccines that we have. It can be offered for post-exposure prophylaxis in the days following immediately following exposure. And then adults, travelers, healthcare workers who don't have evidence of immunity need to make sure that they become up to date. It is an airborne disease, so those facilities that see a suspected measles case need to adopt airborne precautions, ensure that the individual and their contacts know to isolate, and we can help with that. And again, I can't stress enough, it is an immediately notifiable condition, even with suspicion. Kudos to one of our healthcare providers a couple of months ago did notify us of a suspected measles case. We jumped on it. DOH was able to jump on top of it. It turned out not to be a measles case, but I'd rather have tens or hundreds of concerned suspected measles cases that we're able to respond to quickly that don't turn out to be measles cases, rather than having one case that we missed. I've included some references here, and we'll end my portion and switch over to Dr. Melnick and Alyssa Carlson's presentation. Great. So I want to provide thanks, give thanks to Dr. Melnick and Alyssa Carlson for joining us today. I wanted to give a proper introduction, and in thinking about it, wanted to just share with the audience how fortunate we are to have Dr. Melnick join us. He has an amazing list of credentials that is hard to be brief with. He's been a health officer in Southwest Washington, I think, since around the time that I got my first Tdap vaccine. Has an amazing amount of experience. He's currently the chair of the Health Officers Committee of the Washington State Association of Local Health Officials. So in that role, he's mentored me and countless other public health officers renew their roles. He's provided leadership on not just local and state levels, but national levels. He has faculty appointment at OHSU, has researched and published extensively on public health preparedness, outbreak investigations, a lot of the successes that he's met with. And, you know, I was thinking, I was driving down here, who in the world wouldn't want to have Dr. Melnick present to them on measles preparedness? And I realized that Dr. Melnick is probably our state's greatest foe to contagion and pestilence. And if I were a measles virus, traveling internationally, hoping to land somewhere and start the next disease outbreak of epic proportions, Clark County, Washington is the last place that I would want to end up. So I'm excited to have you all hear from Dr. Melnick. Alyssa Carlson's going to have immediate credibility here east of the Cascades. She got her bachelor's degree at Washington State University, worked there for a bit before going on to get an MPH in Hawaii, and then came back to Clark County and was the infectious disease epidemiologist there when their measles outbreak occurred in 2012. So has intimate knowledge about outbreak response, and is now their infectious disease program manager. So it's an honor to have you guys with us. Thank you for taking your time to come see us here virtually in Chelan-Douglas. And I'll let you guys give your presentation and just tell me when to advance slides.
Alyssa, you're going to start off, or yeah.
I can do that. I can do that. Thank you so much for the warm introduction. Let's go to the next. A brief overview of what we're going to chat about today. I actually am probably going to skip measles history and epidemiology because it was presented so beautifully just a moment ago. So we can spend more time speaking about our recent outbreaks as well as barriers and lessons learned from those investigations. So yeah, let's skip to the next slide. The next slide, because you already had that figure. It's, the reason we're all here today, right? We're seeing a lot more measles cases following elimination than we have in the past. And the reasons being, which has already been discussed, lower MMR coverage, as well as growing global measles activity, which increases the chances that an unvaccinated person is infected with measles while abroad, and then they come back and return to the US, where they are able to transmit to groups of susceptible folks. Next slide, please. Ooh, you might need go for it. Let's just keep going till my whole timeline shows up. And that's exactly what we saw on New Year's Eve back in 2018. So there was an unvaccinated individual that traveled internationally, came down with measles, and basically started our outbreak. Thankfully, on that fateful day, again, New Year's Eve 2018, the provider immediately suspected measles, gave me a call. Actually, I was 2 months into the job while the patient was in clinic, where we provided specimen collection and infection control measures. So again, a very brief timeline of the event. Although specimen collection was prompt due to the holiday and inclement weather at the time, we didn't actually receive test results until a few days later on January 3rd. By the following week, we had an additional 12 suspect cases reported to us, all of which I think then became lab or EpiLink confirmed. We then stood up our incident management team early the following week, and we remained in response for a couple of months until well after the last known rash onset, the outbreak being declared over at the end of April in 2019. Go ahead, yes. So this is the epi curve for the outbreak, where it demonstrates the transmission setting by rash onset. It's a little hard to see here, but essentially what you can tell from this figure is that public exposures occurred primarily in the first 4 weeks of the outbreak. And following our control measures, most cases that were identified later in the outbreak were actually already known contacts in quarantine and active surveillance, which then decreased our public exposures throughout the outbreak. Next slide. It's kind of funny to try to summarize this really significant outbreak in a nutshell, but I'm going to try. We ended up with 71 Clark County cases. We had a few gifts for other local health jurisdictions, both in the state and across other states where cases came from this outbreak. 73% of our cases were between the ages of 1 and 10 years. We had no cases of infants, essentially. Contact tracing involved 4,000 individuals among 46 known public exposures, as well as social gatherings and other home settings. And there was a huge amount of public and media interest as well, as you can see through the number of interviews, articles, posts, and news releases that we did. Next slide. Dr. Melnick, is this you?
If you want to go, you can go do you want to do the 2020, or you want me to do this one?
I can do it. So let's fast forward to almost 5 years exactly to the date. Eerie, isn't it? So this was sort of an interesting exercise in how it became reported to us. And the lesson learned here is just to be vigilant, keep an open mind, and be conservative in what you're hearing among your community.
So essentially what happened was my team received a report of a provider whose patient thought they were suspected or exposed to measles. So we were a little far off from our normal reports here. The information that we were able to collect initially was just concerning enough that we didn't write it off. We, kind of probed and collected more family information and try to interview folks to just really suss out what was happening here. What we learned is that there was a family who believed that they had measles among their family members due to someone who had traveled internationally. Their symptom profile matched pretty much exactly with what you would expect. And so we partnered with Wahkiakum County to try to facilitate testing and verify the diagnoses because none of these individuals, despite being symptomatic, had sought care. Forgive me. Actually, I think some folks did seek care, but they were never actually tested or reported to us. So we had to go through and do the legwork to get specimens collected and then tested. By January 5th, we had confirmed 3 cases by urine PCR. We then re-interviewed the cases, performed additional case finding and contact tracing. There were 2 healthcare facilities with a potential exposure. Thankfully, all had evidence of immunity. Several days later, towards the middle of January, we had 2 additional suspected cases reported to us. And again, we kind of had to be creative in getting the specimens collected and then shipped up to public health lab for actual testing. There was some issues with the serology that was run at public health lab, and those specimens had to be forwarded to the CDC for confirmatory testing. And that does take some time. So about 10, 11, 12 days later, positive serology was reported by the CDC for these cases. We then continued to work with community partners to evaluate and test other suspected measles cases. And our outbreak surveillance continued until February 10th. Next slide. So these are just the general case characteristics. We had 8 cases among Clark and Wahkiakum counties. 6 were lab confirmed, and 2 were epi-linked. All were unimmunized. They did all report quarantining and isolating upon recognition of the symptoms within their families. So that really decreased, I think, the spread and what we could have seen and what we have seen in 2019. Altogether, we identified 20 contacts who were then notified of their exposure and placed under surveillance, either active or passive, based on their immunity status. Next slide. All right, Dr. Melnick, I'm going to let you talk about the barriers.
Great. Thank you, Alyssa. Great introduction to this. So, and I'm going to actually use both the 2019 outbreak as well as our 2024 outbreak in terms of talking about this. And, unfortunately, in the 2024 outbreak, we really didn't have much in the way of public exposures. But I also want to point out that the measles virus is, I use the term exquisitely contagious. It's one of the most contagious viruses we know of. And that's why, public exposures are so concerning, because the virus can actually persist in the air for 2 hours after somebody has left a room. And somebody who's susceptible can go into that area and be exposed and get measles. So it's particularly concerning. So one of the barriers you're going to hear about, and this was actually more true in Clark County in 2019 than it is now, and I'll talk about that for a few minutes, but low vaccination rates, especially in some communities. And along with that, low levels of trust in terms of community members not interested in speaking with public health, obtain vaccinations, or pursue testing. Alyssa's already talked about, in terms of talking about the 2024 outbreak, the issues around a lack of testing by community physicians and other healthcare providers. And I'll talk about, lessons learned we've had about that. The weather certainly can, you've heard how that can create problems. I think that Education is both for the community as well as healthcare providers. There's a lack of understanding about measles itself, the infectious period, which one of the challenges with measles is that folks may not understand that the period that you're most contagious is 4 days before rash onset until 4 days after rash onset. So people will be very contagious, and before the rash begins, there's misunderstanding about that. And then just the general issues around stigma associated with communicable disease, infectious disease in general. And then we've already talked about low MMR coverage. It goes along with low vaccination rates. So we'll talk about that a little bit more. Next slide, please. So I'm going to talk about the 2019 outbreak because that's a more of a concerning scenario, although one measles case. So, in terms of an outbreak, one measles case is technically an outbreak because we shouldn't be seeing any measles at all in our community. And we thought we had eradicated it from the US, but we haven't. But one of the things we did in 2019 is to rapidly initiate emergency operations and standing up the IMT. You notice when Alyssa showed that epi curve, we confirmed the first case on the 3rd, but then around January 12th, and it became apparent to us that we were having significant local transmission in our community. And given how contagious measles is, we know we were facing potential disaster. So we got into emergency operations immediately. And I'm pointing this out in case, unfortunately, you all suffer from the same fate. But we got out provider health alerts and advisories, media releases immediately. We updated our website and social media. We immediately initiated notification and contact tracing. And then we activated our medical reserve corps, our volunteers, and our local health jurisdiction mutual aid agreements to help respond staffing needs. And we ended up having assistance even from other states. If I remember correctly, Alyssa can correct me on this, but we even had some folks from Idaho who were helping in our response, local public health folks from Idaho. So, and we have an article out about the expenses incurred in this, but emergency declarations not only help with increased staffing, but also help with expenses that incurred, and they were significant. Next slide, please. Our outbreak measures include identifying exposed persons and assessment of their presumptive immunity. I think you're all familiar with the drill around this in terms of, I put the definitions there. We recommended vaccination of persons lacking presumptive evidence of immunity. We administered post-exposure prophylaxis with MMR, or for those who are unable to, for example, pregnant women who receive MMR, immunoglobulin, and we immediately implemented social distancing strategies, which were isolation of patients and home quarantine of those who were exposed, who did not have presumptive evidence of immunity when they were exposed. So immediate isolation as well as quarantine. The predominant settings for our outbreak were households and churches, as you can see the numbers there for the 71 cases. Next slide, please. The other thing that we had to do, based on how contagious it is and how challenging it is that we had to notify people who were exposed in public sites who may not otherwise been aware of their exposure. So, for example, we had one of our public sites was the Moda Center in Portland, where the Portland Trailblazers play. And you could think about the potential of, how many people might have been exposed and to measles there. So we actually identified and publicized public sites where exposure may have been taking place. Then we couldn't identify individuals who were there, so we put out press releases. And then we identified other sites where we were able to identify particular contacts. So we worked with hospitals to find out who might have been in the emergency rooms at the time the cases were there, up to 2 hours after the case was there. Same thing with clinics. And then we were able to try to identify those individuals and get them information about preventive interventions and maybe even get those administered. I would point out that we believe, I'm putting this in lessons learned, but we believe this was successful because you can see that during the first 4 weeks, as Alyssa already mentioned, public exposures were the most common, but of the 30 of the 71 cases identified after February 1st, 87% of those, 26 of the 31, were under quarantine and under active surveillance. So they were not in public spaces during the time that they may have been contagious. And so 87% of those. So that's how I think lessons learned in terms of this full bore attack on this is how you can get a handle on this early on. Next slide, please. And I think Alyssa already showed that, but you can see on this epi curve, and we'd be happy to share the slides. You can see that most of the cases after February 1st were household cases, and they were in quarantine and not exposing other people. Next slide, please. The other thing that we did was even though several cases were associated with a specific population, and I think we've already heard that, that we're seeing more cases in people coming back, unimmunized people coming back from countries where there's a lot of endemic measles, and actually communities here that where there are specific communities where with low vaccination rates. We adopted a strategy of social distancing and vaccination strategy for the entire county, not just for those specific populations, for a couple of reasons. One is that transmission occurs in public exposures. So cases, in our experience, when we had these cases, they were not confined to one population. The vaccination rates, unfortunately, were low throughout Clark County. They're actually lower than they are now, putting other populations at risk. And with measles, you need about 95% coverage, either through having had measles or vaccinated to prevent transmission, herd immunity. So we're well below that. The other advantage of targeting the entire community is it helped avoid stigmatizing and appearing to blame a specific community. And we're aware of this, in our recent outbreak as well. This can inhibit, we already talked about trust issues, but this can inhibit cooperation as well. And the other thing that blaming a specific community does is it misrepresents the risk to the rest of the population. Just because we might have had a higher rate in one specific community doesn't mean that the rest of the population is not at risk. We needed to maintain trust and cooperation. That helped us facilitate rapidly and effectively identifying exposure sites and active surveillance, as well as home quarantine. And the other thing I'd point about targeting the entire community, if you look at it, we looked at numbers of both kids and adults getting a vaccination in Clark County and compared it to the previous 5 years. I should have shown you these graphs, but the amount of vaccine uptake, and Alyssa probably remembers this, in January, February, and March was incredible in the community and among the general population getting MMR vaccine. So that helped there as well. Next slide, please. The other, the lessons learned in general was building rapport with community members, providing ongoing community provider education. We already talked about informing healthcare providers about tests and getting specimens. Collaborate with DOH and other. DOH was a great partner in this, as well as other LHJs and local health jurisdictions, and invest in immunizations. And I think that might be our last slide. Let's see. Yep. So we finished in time for questions, but I figured you know, the lessons we learned will hopefully be useful lessons for other folks. Hopefully, none of you, my only claim to fame with measles is I happened to be in the wrong place at the wrong time. That was about it. So, folks have questions, we're happy to answer them. This is actually giving me a little PTSD actually talking about it again. So, for my therapy.
Sorry to put you in that place. I know how that is. I know that, well, thank you guys so much. I know Jordan's been monitoring the chat, and I think we've had some action there. Does anyone want to raise a hand with a question, or Jordan, you want to start in the chat?
You don't have any questions?
No questions in the chat? All right, those are our folks signing in. Kathy Muret has a question from our audience here.
I was wondering what percentage of students are attending school who are not fully vaccinated? Was that an issue?
Yes. So, and actually, you know, the DOH has a great website on this. You can actually click on the school itself, including in your community, and you can look at it by buildings about schools. And that's really actually, if you want to get scared, I mean, I've done this, and there are some schools, depending on the school, it varies by school, and there are some schools with incredibly low vaccination rates in the K through 12 population. I think countywide at that time, and Alyssa, correct me if I'm wrong, we were in the, you know, if you looked at the average in K through, you know, in kindergarten, I think we were like in the 80s, in the 80%. We were well below the 95%. I got to tell you that in those 3 months where a lot of people got vaccinated and beyond, you know, when we targeted the general population, our vaccination rates did go up pre-pandemic, and now they're dropping, you know, with all the misinformation out there, they're dropping again somewhat, but they're higher now than they were in 2018, 2019. But it varies, it certainly varies by school district and by school building. But we were well below the, you know, 90-95% kindergarten as well as K through 12 immunization rates for measles.
Thank you.
Yeah, thanks for that. Lori Jones has a question, but on the school vaccination rates, do you guys follow the school reported rates or the WIS rates when you're looking at local numbers?
I'm going to let our epidemiologist, I mean, I think I know the answer to that. I think it's WAIS, but I'm going to let Alyssa pontificate on that a bit.
We consider both. Thankfully, all of our school districts here in Clark County are already onboarded into the school module in the IIS. I think there's one that's in the process of doing so. And so the IIS is our best, our resource for that.
And Alyssa, there's kind of a delay in the school data, right? When in terms of people reporting into it. Am I correct?
There is, and that's been one of our immunization projects and in the past, we've actually deployed MRC nurses to help get schools caught up on their data entry. So that's another way to invest in immunizations, is for that data to be readily available for response when needed, because it was a huge burden on the schools to sort of do their record keeping in the moment when they had exposures to measles in their schools, and having to communicate to us who's susceptible and who wasn't. In the very beginning, we actually had the school nurses and the school teams perform that work, but we quickly realized they were overtaxed, and it was more appropriate that public health would kind of just step in and perform essentially the contact tracing and evidence of immunity verification for schools.
By the way, I'm a big Lori Jones fan, so call on her for the next question.
Dr. Melnick, it is so good to have you presenting on this side of the mountain. I just love it. For those
even
of you
virtually, huh, Lori? Okay, yeah, we'll go for it.
For those that have never heard his talk on ethics, it's amazing. Which brings me to, as Okanagan County is having some difficulties with vaccine misinformation, particularly, say hypothetically, providers signing exemption, religious, personal, and medical, when perhaps they may not be that, for especially around MMR. What was your experience, and this is for both you and Alyssa, in combating misinformation, especially from the medical community?
Yeah, that's a great question. So I'd point out that one of the benefits, I don't call it a benefit, of our outbreak in 2019 is it led to legislation that passed that removed the philosophic exemption for the MMR. So that is the one immunization in the state of Washington that there is no philosophic exemption for. It's just but the other thing that you may have noticed is that once that was eliminated, which was a good thing, the number of religious exemptions increased. So I think overall it helped, but that increased. The religious one is really difficult. I think in terms of enforcement and dealing with providers, that's a difficult one. But if you really if a provider is the number of medical reasons, medical exemptions, it's rare. I mean, the vaccine is incredibly safe, so the number of medical exemptions are rare. If you believe a provider is making up a bogus medical reason for an exemption, that's something you can talk to the medical commission about. I mean, that's a possibility. I don't think we've done that, and I haven't seen. Alyssa, I don't think we've seen any bogus medical exemptions, have we? If you did see one, I mean, that's something you could talk to the medical commission about. I don't know if that answers your question, but
No, I really appreciate your insights, especially having gone through the outbreaks that you have.
by the way, I don't know any religion that is, I mean, you all may know of some that I don't know that really has a it's against a religion to get vaccinated. That as you know, that came up during COVID-19, and I think the Catholic Church put out some great statements about not being, the vaccine was okay. So, but I think going on that one is very difficult. Trying to use our enforcement around that it would be difficult, impossible, and it's not going to increase trust in the community. And I think it might be more problematic than beneficial.
Right. Thank you so much. It's really good to see you.
Likewise.
We have a question in the chat. For cases with unknown exposure, were those just lost to follow-up, or did the individuals truly not know where they were exposed?
I can speak to that. I will say, especially for those cases who had onsets later on in the outbreak, we have a good idea of where they were exposed, but we couldn't prove it definitively. So where we sort of identified transmission settings is through the case interviews as well as medical record searches. We are quite certain that some folks were social contacts of others, but we're unable to confirm for a handful of individuals.
So being the early learning person in the world, a couple of questions came up as I was thinking about this. And my one question is, because I did this years ago and haven't done it in a while, but in the reporting part, reporting something like measles, in an early learning center, quite often that's going to be a phone call from a parent in the morning saying their child has measles and they aren't coming. Do you still report that event? Is that still reported? Or is it the doctor who said who reports it?
So notifiable conditions, I think it's under I'll be technical here. The Washington Administrative Code, chapter is at 246. You can look up the notifiable conditions there. There are three groups that have to report notifiable conditions. And that includes, suspect as well as confirmed cases. Well, we appreciate when they provide the suspect information as well, as Dr. Wallace said, but it would be healthcare providers, licensed healthcare providers have to report, laboratories have to report, and hospitals, healthcare systems have to report. And you can look, I think I put the list of notifiable conditions, link to that. You can see the guidelines there, but WAC 246, you can actually see, whether a condition is immediately or within a business day, and all that. But the public, there's no requirements, there's no, and the Washington Administrative Code has the force of law. But there's nothing that requires, individuals to, patients to report. I think that would be problematic because we have a lot of noise in the system. So if somebody suspects they have measles or other notifiable conditions, what I would say to them is call your doctor, call your healthcare provider and have them do an evaluation. I wouldn't have them run in if there was concern about measles. I'd have them, if their child had been exposed to measles or they thought they were, I wouldn't have them run into the office because we don't want to expose people in the office. So the best thing to do is have them call their healthcare provider's office immediately.
So
I don't know
yes,
if you want to add anything to that.
on the list of one of the things that an early learning program would have to report. I know that I was just trying to figure out, like, just because I got a phone call, right, from a parent that said their child isn't going to come and they're keeping their child at home because of measles, is it my responsibility or their doctor, or do I just assume their doctor did the reporting?
Don't assume anything.
Yeah, I think this is a great opportunity to share, and Kathy Moritz here might know the requirement of school nurses to report. But in our first pertussis case, the healthcare provider did not report it. The school nurse reported it when she found out. She's on the call. She can share her experience if she'd like to, but the school nurse reported it and alerted us, led us to jump on top of things earlier than we otherwise would have. And I think saved a lot of transmission and led to a lot of good work.
That's a really good point too, because even though healthcare providers are required to report, we get most of our reports from labs. It's electronic reporting, and that could be really late in the game. So one of the things you want to educate, our partners about, including healthcare providers, school nurses, and all that, is the need to report. And but people forget that.
So I guess my other question too is that there seems to be a great deal of tracking, like in what the public school systems is doing and the outbreaks and all of that, but has there been much tracking around what's happening in childcares and Head Starts and ECAP programs around tracking and immunization records and those kind of things?
Alyssa, do you want to answer that?
That is actually another one of our current focus areas, is getting childcare centers who, I believe, if they have a student population of 12 or more, are actually required to report into the IIS. And so we've done some surveys to outreach to these facilities. One, are you reporting into the IIS? Two, do you need assistance on meeting that requirement? And so that's something that we've been focusing on this spring through over the next couple of years, is to help them as well meet that requirement and to have all the information and their ducks in a row. Because it doesn't just help with measles, it helps with chicken pox, it helps with pertussis. It really just helps wrap your arms around any emerging situation.
Yeah. Okay, thanks.
I had a few questions. This really generated a lot of curiosity, imagining myself in the position you found yourselves in. At what point do you determine that a public site is should be disclosed as a place of potential exposure? Because we've discussed that certainly discussed it with pertussis, say naming the schools that were involved. We have not done that because of the same line of thinking that Dr. Melnick shared, that we don't want to give people a false sense of security when we know community spread is occurring. At what point is that helpful?
Yeah, I'm going to speak in generalities about this because it might depend on the specific circumstance. But for something like measles, which is contagious as it is, it depends on whether you're able to identify everybody who might have been exposed at the time the case was there. So if you have a public site where you can't, there's no way of you knowing who is at that public site. Let's say it's a bank. You know, somebody walks into a bank with measles. You don't know who all the people in the the customers are. Let's say it's a grocery store or a restaurant or something like that. If you can't, well, restaurant, you probably wouldn't be able to identify all the patrons. If you can't identify everybody who was there and could have been exposed, the only way to reach them is to name the public site and talk about the time period when people who were there were at risk, and publicize that and get a press release out. If you have a situation like a clinic where you have the patient roster and you can identify not only who was there, but in talking to the folks, identify who may have brought them in if they weren't on the schedule itself, then you might not have to do a public exposure on that. But the bottom line is with measles, if you can't identify people who are at risk, we had actually, the Portland airport was another site of public exposure. And one of the cases was going through the Portland airport. At least one of the cases is going through the Portland airport at the time they would have been during their contagious period. We basically put out a press release about that. If you're at the Portland airport, and I think we even mentioned the concourse, if I remember correctly. If you're at I think it was Concourse C, if I remember that. It's coming back, but there was no way of knowing who all was there, so we did. Jimmy, does that answer your question? Or
yeah, thank you very much. And I think a second to that is, do you advise those individuals to seek care if they develop any respiratory illness, isolate if they develop any respiratory illness? You don't ask that they quarantine, do you?
Well, if the message out is if you're susceptible, you're not immunized, you haven't had measles and all that, and you were in that location, the recommendation is to quarantine for the 7 days, 7 to 21 days. But certainly if you develop symptoms, contact your healthcare provider. But yeah, that would be Alyssa, I believe that was the message we gave folks.
It was. And so, yeah, definitely we ask folks to stay home, and especially if they began to feel ill, to call their healthcare provider if they knew that they were at a place of public exposure based on what we publicized.
I think we also mentioned if they heard about this within 72 hours, which would be really rare with a public exposure because it takes time to identify that. We would have recommended MMR if it was in 72 hours. Unless they were, like pregnant, you can't get a live vaccine. But we would have recommended immunoglobulin if it were within 6 days of the public exposure. For example, if they were pregnant. But we would make the information we got out gave those recommendations as well. So the idea of the notification for in public spaces is not only to have people quarantine if they were susceptible, but also to get prevention if it were within the time frame. But that was difficult because investigation takes time.
Did you have this is Kristen Hosey. Did you have a difference in the response from the community with your communications between pre-COVID-19, so between the 2019 cases versus the ones that you had this year? I was just curious if you had seen any challenges with asking for isolation or those extra measures at all.
Yeah, I'm going to let Alyssa answer this, but I just want to make one point, which is a little bit unrelated to your question. But in 2019, we ended up having to deal with a lot of vaccine misinformation. And I thought that was really bad and really difficult to deal with until the pandemic came around, and it was like the harbinger of that. But we experienced on a smaller, somewhat smaller scale, a lot of the similar misinformation around that we had to deal with. And it was one of the lessons learned, is that we had to get out, and we use social media for that as well as to get out the appropriate information. But I'll let Alyssa answer about the response of the population that was affected, whether it was different in 2024 versus 2019.
I will say we had challenges in both outbreak scenarios, and because the scope of each was so different, I'm having a little bit of a hard time drawing comparisons. I will say, with the 2024 cases, building rapport with the affected individuals and just kind of meeting them where they're at, displaying the empathy, that went a long way in getting these people who really, to be honest with you, did not have to go, no one was compelling them to go and get their specimens collected. It was really an ask from public health, and we had some stellar case investigators who are really great at building rapport. And so they were able to get that done. Like I said, I think a couple of folks at some point or another in their illness had presented to care. Measles was never on the radar, so obviously specimens weren't collected. So to get folks who were ill, had already been seen, to go back into a clinic to get their specimens collected, really for the good of public health more than anything else, was a huge accomplishment for the team. So I would just say, invest in immunizations, but invest in relationship building as well.
Yeah, you don't want to use enforcement should be the last thing you're trying to use. It basically in the long run makes things worse. So
Thank you.
I want to give everyone an opportunity to step off. We're at time, we're beyond time. Thank everyone for attending, and Dr. Melnick and Alyssa, thank you guys so much. I can certainly stay. I think Kristen can stay. We've got lots to talk about now after this presentation, so I really appreciate it. We see Pertussis as, our training grounds for something bigger and worse, and really appreciate you guys sharing lessons learned and helping us along the way.
we're honored to be invited. So thanks for the opportunity.
Thank you.
Thank you. Good to see you.
Bye, everybody.
Thank you.
Bye.
Happy to continue to answer questions, or if anybody has ideas for next steps locally, please share them.
For really quick early learning one. I get to talk to the new early learning director, but I think there is a course that taught 2 quarters here, a health safety nutrition course, that it would be nice to have a speaker come and speak.
Yeah.
Because they're providers, our staff, and have them speak so I can.
Well, you got my info.
Yeah, get in touch with us. I've found that the more we talk, whether it's present or attend presentations, create spaces where we can dialogue, I think the stronger our systems become, because none of our organizations can tackle something like this all by themselves. It is, the only way to accomplish good outbreak response is in collaboration. And I think what underlies a lot of the success that Clark County and some other counties have experienced is they've got really good coordinated systems between public health, community partners, healthcare, schools, all the players that need to respond. And I think we've got fantastic relationships. I think we have invested in relationships. We need to continue that and do so with a kind of preparedness perspective, knowing that there's a lot on the horizon that we could experience, and that we could do it well, or we could miss opportunities.
When we teach this course up on reservation, would we contact the health district in Okanagan County to do it, or?
Lori, are you still on there?
Oh, there's.
I think with the Colville reservation, I would say at least invite both.
Yeah.
You know, tribal health and Okanagan County Public Health play oftentimes dual roles, but oftentimes one organization's, you know, authority, overlies, the other. And, you know, I know in Okanagan County, we're very, very careful to collaborate and not step on toes or miss opportunities to do the right thing.
Mhm.
Yeah, I really appreciated the comments about, you know, it's really hard to get anywhere by, you know, just trying to enforce without really having that relationship, and particularly in the schools with the parents, you know, the comments about, you know, the fact that, that there was kind of an uptick a little bit in immunizations, but, you know, then they start to dwindle off again. And, I'd really like to hear more about their messaging and, the different groups, you know, you could, because I think a lot of us might have preconceived ideas of that when they talk about groups that have low immunization rates, you know, who are those groups? And you begin to pocket people into these different groups, and it's not necessarily even people within that group. It could be somebody that you never even suspect would be needing to have some guidance or more education about immunization. So all that different messaging, including, you know, to our tribal parents as well, you know, how to message it correctly, you know, and build that relationship with them, you know, increase those immunization rates.
Yeah, I think we'll be following up with their communications team for sure, because we're wanting to create some regional plans for outbreaks. I thought it was interesting that they used also an MRC, which is a medical reserve corps, because we're starting up a medical reserve corps. So it's given me some ideas on some uses for volunteers. I'm not sure if Kent or Lexi are on there, but that's something that we're working on with Chelan-Douglas. And that could be a thing. It sounded like they sent the MRC nurses, which are typically like somebody maybe retires or has more time in their hand and they want to volunteer, to go do more of that communication with the schools or the early childhood centers to just make sure folks are connected and understand what to do for reporting or other situations. I think it's really important.
Yeah, you know, we've realized, and I think everybody realizes this was realized during COVID, it's, you know, we're seeing it with pertussis, but when you reach the point that you need to stand up an incident management team, you're at a point where things need to move quickly and you really need to have protocols in place so that you can train the large number of people that need to assist you. If you find yourself needing to develop the training manual at the time that you need to stand up the IMT, then that's kind of a missed opportunity. I've done some homework before.
Build that, was it ship while you're flying it or driving it or whatever you do with it? Float it. I see Lexi's on from Chelan-Douglas Health District. Lexi, do you have you want to give a little update on the Medical Reserve Corps? If you have the ability, like timeline maybe.
There we go. Had to find the right button. Yes. So the Medical Reserve Corps, we've got our website up and live, and we are starting the active recruitment. I do have an ARNP that will be joining. She lives in Kashmir, but recently had moved there. She had been in the Snohomish MRC, and she has a very vast background. And then I have another nurse that's an RN that's looking at joining us too. So we're just at the beginning stages of recruitment. We did radio ads that'll be playing, I think, in the next couple of weeks here. And the website information's up and posted. So if anybody can help spread the word that we're accepting volunteers, We also have Anthony Stone. He's one of our CDHD volunteers that's also a member of our CDHD team. He's an instructor in a program called Stop the Bleed with the Department of Defense. So that program teaches people how to save lives by stopping the bleed, allowing extra time for those first responders to arrive on scene. So he's already out working with schools and teaching that class. And we have our first outside event coming up on May 18th. The Multiple Sclerosis Walk has requested support for their first aid booth. So we have volunteers to staff their first aid booth. So we're up and starting.
Great, thank you.
Mhm.
Right.
Right. Well, thanks so much, everyone. Jordan, I know posted a survey. Please fill that out. That helps us in planning. That helps us consider future topics. If folks on the call have ideas for future topics, please let us know. We certainly want this to be as useful to everyone involved as possible.
Yeah. All right. Otherwise, see you August 1st. That's the next one. Have a great day. Thanks, everybody.
Thank you so much.